input coming into all these inputs are working in ways where they're paired up, and a lot of vision, hearing is paired up from both sides, and I think movement is also getting input from both sides, but more heavily from one side. And that may be why, like, little babies who have these devastating strokes and stuff go on to move normally and walk around normally, because probably there's some minor innervation on both sides, young age, and lose the brain, that it's able to compensate. As we get old, they call it plasticity, but and that's less likely. But yeah, so there, and that's the great thing about neurosurgery, is that I got involved because I thought I was excited to learn new things, and we're still learning new things about the brain. So there's a lot out there.
Thank you. Quick follow-up question. Can you recommend a book for a lay reader who has some science background, but is not a doctor or neurologist, to learn more about these topics?
That's a good one. I'd say go to the internet, but the internet's so full of different stuff.
And I mean, not just the like brainstorms and things like that, but something that's a little deeper into the science.
Yeah, well, I'm trying to think. That's a really good question, because I think particularly people with PD, people really want to learn. I have a friend who's an engineer who is very, has PD now, and he's super interested in, people have a lot of expertise in various fields, and have clearly the capacity to understand this stuff. And I don't know of a good sort of in-between book between the super professional stuff and goofily, I don't know, but that's a really good question. I will check it out.
Thank
you. I think Scientific American and stuff probably has stuff, and the only thing sometimes is that what I've noticed is that old doctor stories. So when we went to school, in medical school, we were told, so that's like 40 years ago plus. I don't know. And they say, oh, your brain, and when you're a baby, that's all the brain cells you get, and that you're never going to get any more brain cells, and you just lose them from there on. Well, it turns out, peak creativity is at 40 years, and anyone who's watched a teenager realizes things are changing in that kid's brain. And so it turns out that the brain makes new cells. So a lot of things we know as fact right now are completely wrong.
That's a good laugh line.
It is a good laugh line, but it's true. And I think the realities are that some people want all the answers. We don't have them all. And then, and so who was it? Some, towering figure of neurology was describing the brain in a talk I heard. And in Parkinson's, you guys have probably seen them. There's the box diagrams of how this striatum talks to the globus pallidus, and they go, the brain is not full of boxes. And so it turns out even those people who worked out the basics of this stuff, it's just the skeleton picture. And so beware of these things, because I think some of the reviews will be old stuff. But I think Scientific American, looking in those kinds of places, might have reviews. And there's reviews online you can find, but again, I would get them like from Nature or Science.
Yeah, sometimes I feel like researching on the internet, I get lost in the wilderness.
You do, yeah.
So much stuff.
Thinking about the journals, so something reputable. And Scientific American, I don't read as much now, but in the day it was pretty good, and they have good general articles. And again, Science and Nature, they have reviews, but they tend to be a little bit more doctory heavy, so they're a little harder to understand.
Well, maybe I will look there. I have degrees in biology.
Mm-hmm.
And so I am not a doctor, not a medical doctor, but I know, I taught basic biology in grad school as a teaching assistant. So, yeah.
Well, and I think we all have some interest in the other side of it. I'm reading, I just took a trip of a lifetime, went to Patagonia. Ooh. But you have to look up like word after word about, where it is, or, some Indian tribe. So I'm spending time reading with my cell phone right next to me and just looking stuff up as I go to try to get an idea. And in the end, if you feel confused, then you probably read it right. Because if you think you understand, that's when you really get into trouble. And honestly, to get the big picture, it's the really fun part is to realize that this is what we know and there's a lot we don't know still.
Well, thank you.
Sure.
Right.
And we
Well-
can freewheel this a little bit. I was fortunate enough to get a little bit of a list. I don't know if we want to go through the, kind of start there. And again, I'm happy to talk about anything. And I have, this is a little different. It's nice to talk to the support group people. When I used to have this, I called it Meet the DBS Doctor, only because I A, talk too fast, and B, talk too much. But I think this is a really interesting topic, and people who either know somebody, everybody knows somebody, or has it themselves, or want to know more information. And so I learned through the hospital that doctors are just supposed to do surgeries. They're not supposed to talk to patients anymore. And that's why they have nurse practitioners like Kathy and whatnot. But I think talking about this with people who are interested is super valuable. And hold on, I'm trying to get that list you gave me.
Dave, I also wanted to let you know, Robert, who's joined us today
Yes.
by request,
Okay.
is young onset,
Okay.
DBS, and Duopa.
Okay.
Duopa following the DBS. So he's somebody who's had experience. We were looking for someone who, could answer questions as a DBS recipient.
That's great.
So I just wanted to let you know that. And Robert, thank you for joining us. You're muted,
Well, that's
Robert, by the way.
There we go.
There you
Thank you.
are.
Yeah,
There you
thank you.
go.
Thank you.
Well, I think this is challenging for me, but no, but it's great because the doctors usually get up there and tell the story. But I think the real story comes from patients who had the process and know what it's really like from the inside.
Mhm.
And that to me is great, actually. Well, is it Robert? I can't see anybody's name. That's kind of the.
Oh, yeah, I'm so sorry. Yes, Robert.
Robert, yes.
Robert, howdy. So Robert, what do you think the most important thing for people who haven't had this is, that you didn't hear when you talked to all the people before you had the surgery? What was kind of the thing that you learned you didn't know and people should know about? If that's okay if I ask.
Scared of it, and I was just waiting. I waited way too long. I mean, I probably waited, way too many years. I started at like age 45 with it, and I didn't get it till just a few years ago, but I'm 62 now. So I think I could have benefited earlier on. I just struggled way too long. It was the last ditch effort to me I was pretty desperate. And I kind of forced into doing it. I was just in bad shape otherwise. And it made a huge difference. Didn't solve everything. In fact, that's why I do the Duopa, because Duopa helps me in things that DBS did not quite do. And DBS helped me in certain things that the Duopa, they kind of both help me in different ways. And I think I would do it over again the same way I did it. I would do the deep brain stimulation probably a little before I did it. Well, quite a few years before I did it. And if Duopa if that didn't solve it for someone, I'd say go for the Duopa too. I mean, it's no fun having all this equipment and things poking out your stomach and whatever. But the brain was really traumatic going in. But after I've got it, it just goes smooth. I'm charging up my battery right now. It's a pretty easy thing to do. So.
Well, I think you make a couple of really good points. The first one I'm going to say is super basic, because one of the questions, the only one I remember, I still can't find the questions, was who's a good candidate for DBS? And so candidacy for DBS really need to be responsive to levodopa.
Mm-hmm.
And so on and off evaluations, I think, are valuable, because that's just the insurance companies want it. But I also think it gives the patient an idea of what's going on. But it's a big predictor. Also, you'd rather have patients have Parkinson's for a while, maybe 3 or 4 years, because there are the nasty variants, and PD can be, or what is it? Parkinsonism can be a harbinger of something worse, which DBS does not help. So you want to make sure it's going to work.
Mhm.
And waiting is a big thing, but I want to talk about that second. But the DBS works hand in hand with the medication. So you're kind of a unique guy, but I think that the big goal is to try to get the levodopa in there in a more constant flow, and then people are still working on that.
Mhm.
And it makes sense that you would see improvement. And not everybody wants to go through 2 procedures, but if you need it, I mean, it kind of underlies the whole fact that deep brain stimulation helps, but it doesn't do it by itself. And in the old days, when we first started doing this, people were putting things on the internet. Oh, I'm free of my Parkinson's medications, but quickly realized you needed to. And actually, one of the guys at UCSD did a study, which I talk about, but I think yours is much more telling about, why, or at least the basics of it, is that DBS and medications work to the same end, but work in a different pathway. And so having both working probably is an advantage if one needs that. So I'm glad to hear that you had that. And I don't know how much they do here, but I remember going to meetings and seeing people who were on Duopa, and they were looking fantastic. In fact, I thought, oh, DBS is done. But I think both have a role, and it points out that the therapy by itself, DBS therapy, requires good medical therapy. You need to be on Cinemet as well.
What are the
Which
different
probably sounds cool to
pathways?
think about the brain.
What are
What's
the
that?
different pathways of medication versus DBS?
Well, and so, having done this for a while, well, can I get to one thing? And the age thing is the thing too. And I think that's what's slowly changing, because the first FDA rules were patients have had the disease for 7 to 9 years or something like that. And that's a long time with all the symptoms of Parkinson's. And who wants to have brain operations? But it's when you have Parkinson's, my old analogy is that, it's like rocks in your backpack, but you get more and more rocks where you can't do anything. And if you could be free of those things for a couple of years, that's why it's hard to sell DBS, but patients frequently say, I wish I had done it sooner. And I think we're getting into that phase now where before it was just early adopters. Now people are starting to recognize that it's valuable after a couple of years when the medicines aren't working. And that's the other thing, is when the medicines don't work well for you, that's where you should think about DBS therapy. And I apologize, where were we going before
You were talking about the medication and DBS work along different pathways, and I wanted to know
pathways?
what they were.
Yes. Well, good question. So when I first gave my first lecture, how does the DBS work? And I had this crazy diagram up because nobody knew how it worked. And it was the history, which as an old person I love to talk about, and is in the old days, the anatomists figured out the motor pathways and then started experimenting with interrupting the motor certain parts of the motor pathways to get rid of the tremor of Parkinson's. And so all the operations were aimed at these hypothetical targets based on, it would be like trying to fix all the streets that go to Padre Stadium and figuring, well, if I can get to the right street, I can solve the problem of traffic control there. And so only recently, and I would say recently, and she was recently in town, actually, the neurologist from Stanford came up with the idea of recognizes that the normal brain worked just like the computers we were talking about, compute a little and communicate a lot, was always talking to each other. And that because energy is expensive for the brain, that the brain sort of prepares at a low frequency, and then when it's going to communicate, it jumps to a higher frequency and then communicates with the cells that it wants to, and then goes back to the low frequency. And in Parkinson's, this low frequency, this beta frequency, was around between 20 cycles a second, 20 hertz, or maybe 15 hertz to 7 hertz, and it's sort of hanging around that, I guess. And in the Parkinson's patients, it's lower. So my analogy would be, it's like a car that can't get out of low gear and then switch so that the cells talk to each other. And and then again, this is me explaining stuff from what I see, but I don't think it's not necessarily exactly what's happening in the brain, but where patients you want to make a move, you want to walk, and you can't get that movement. And then somehow you put the pencil down or the laser light down, you can step over that and initiate the movement, and then everything's okay. So, the bottom line I would say is based on the medications and on the DBS working differently, that it could be different targets, maybe on the same system, or it could be independent systems. And maybe by getting the dopamine, which normally comes from the striatum in the circulation and showing up in the basal ganglia. Again, this is laminar speculation someone talked about. So I guess, and that's why it works.
Okay.
The DBS at the target is what it does is it changes the frequency and then allows the gears to shift even with less medication. So I don't know the pathways, but it doesn't necessarily mean separate pathways. It could just be acting in the same pathway in different places and somehow facilitating the process.
So
But
the
that's
word
another-
frequency that you used,
Yes.
what is it? What is the frequency of? What is what's
So if you in the movie, sometimes they watch the brain waves and you see the little pens going back and forth. And so if you're asleep, the pens go very slowly. And if you're moving or having a seizure, they go really fast. And then what that's looking at is really sort of like a recording from a noisy party with, say, 100 people in the room. And nowadays, what we can do is they put electrodes into the brain. Sometimes you can get into just one party person, one cell, and listen. But a lot of the systems in the new DBS systems like Medtronic gets in an area and they call it local field potential. So it's like listening to the kitchen at the party house. And so you're getting a smaller sample of cells to get this information. But basically, there's an increasing understanding of how the brain's working and, well, observations of how the brain works, and they call it the default network. So when you're just daydreaming, sitting, or kind of thinking about what you're planning, certain areas of the brain, very specific areas, the same areas in everybody, are kind of idling around and getting ready to go. And then when action comes, and systems are
Excuse me a minute, I have
activated,
to
we're
close the
talking
window. There's noise outside.
about, or sure. So the frequencies we're talking about are in the motor system. And
Okay.
with the recognition that the deep brain structures are talking to the cortex, the surface structures, in this link back and forth, everyone's looking for stuff now, and they're recognizing that these communication strategies between different areas of the brain are recapitulated in speech and in vision, but at different frequencies, depending on what they need to do. So the motor system that's why DBS only is thought to really be beneficial for motor symptoms.
So it sounds like you just explained some of the basics of neurology. So is there like a basic neurology textbook that might be worth looking at?
Well, the best ones are the old ones, and they're half out of date, unfortunately. Yeah, again, if you talk to most neurosurgeons and someone calls a neurosurgeon a neurologist, we're very disappointed and insulted. But
I'm sorry, I don't know the language. That's why I need to read.
The reason I bring this up is that I have been fortunate enough, because I was the first resident trained at UCSD, and there were no other neurosurgical people to hang around with, except the professors. And so my young compatriots were all neurologists. So I learned very early that the neurologists were fun people to hang around with, and just as nerdy as I was about the brain. And so so neurology is extraordinarily complex and high art, which has been somewhat replaced by people who don't really think about it too carefully, surgeons, and just look at pictures, look at the MRI scans. But there is a lot of art in what goes on in the brain, and so I'd say neurosurgery is complicated, but it's, there's kind of you go someplace, do something, and get the tumor out. And neurology is how the beauty of how the brain's connected, and everything's connected. That's the first rule, the first joke. Everything is connected, and how it's being connected is not really. I mean, we have the map, the diagrams, because people have been very interested in this for years, but we're starting to figure out how these connections work. So a basic neurology text, Adam and Sue, I
It's
have a book, but
they're
nobody uses
not very,
books anymore. I try to give them to my son. It's really funny. So I don't know where to get to it.
and they're interesting, but they're not that satisfying in terms of getting into some of the nuances that you're describing. Because it's
Well,
just
just-
not,
Right.
it wasn't there when they were published.
So my not
No.
getting what you meant by frequency, and then when you used the word brainwave, I went, oh yeah, I get the
Right.
connection.
But Dave, I was
Well,
going to ask a
and-
question about Dr. Barba about the
Yeah,
beta
please
waves.
call me Dave. I'm almost not Dr. Barba.
Thank you. I've heard that there is some potential in understanding those beta wave frequencies for Parkinson's, that there may be a correlation between certain types of Parkinson's activity that you want to either turn off or encourage, maybe, I don't know, based upon looking at the shape and pattern of those beta waves that DBS can actually have an impact with. Am I making any sense?
Did you say theta, Theta?
Beta,
B.
BETA.
Even boy.
BETA. Beta waves are the ones that DBS is supposed to get under control.
Yeah, the low beta, but yes. And then
you.
gamma is the fast one. And I think what you're talking about, there has been, well, now because of the basic electronic technology, where before we would just put stimulators on the vagus nerve or spinal cord or even DBS, it was just on like a clock all the time, tick tock, tick tock, tick tock. But just like pacemaker technology, now there's systems that are listening. And it's a peek into the, behind the screen of how the brain's working. And in cardiology, then it became therapeutic. So patients had arrhythmias and you could treat them pacing or even defibrillating. And so that was 20, 30 years ago. Now it's starting to happen for the brain or be possible. So in epilepsy, it's been fascinating because people are looking at other diseases, looking for these frequencies like you're describing to see if they're correlated with, say, depression. And so epilepsy has been interesting only because in epilepsy, you have to listen to all the brain. And in Parkinson's, we've only sort of had, again, because we're doing, I say we, the patient and the doctor are participating in a big undertaking. So I can't tell you how many times I talked to scientists, and the more later on, while I was really excited about it, then I was like, I had to become at least in my own mind, the gatekeeper said, well, that's interesting, but I don't think that's really the patient's best interest. But now we have devices that are put in for good reason and therapeutic reasons, and they're starting to gain information. And so part of the problem of understanding, I think, is it's a sacred space, and going there has to be done first to help somebody before you just start looking around. But what is happening in San Francisco, and I think that's maybe what you're talking about. I'm only familiar with San Francisco, but because I think this Percept system is being used in novel ways in epilepsy and in Parkinson's disease, and now in depression, to look for how the brain's talking to all these different, through these circuits which we've seen about, but now we're listening kind of while we go. So, and I saw some great behavioral stuff that Phil Starr showed a couple of years ago, but I am not privy to it. But it would not surprise me that there's different characteristics, and now it's whenever what do they call it, artificial. But it has the time to look at this stuff, and I think the computer power and our ability to actually be in the brain a little bit. I'm going to turn my video off because I think my wife's also doing a video thing. How do I do that? There we go.
There we go.
Okay. So, yes. So there is just now becoming the hint about behavior, but what is on the brink of happening here in the United States, and I think it's already happening in Europe, is using the beta frequency when it's expressed. People are, and there's good correlation with behavior or function, where they're going to use the beta wave as the indicator for more or less DBS, and that's kind of like the baby steps.
Right, I see.
It turns off at night, or if it knows what time it is and senses your activity, and maybe you have a watch on or something. And then we'll say, well, beta frequency, I should treat that, something like that. And then,
So you brought up potential therapies for depression. So that makes me wonder, is there a potential for addressing some of the non-motor symptoms of Parkinson's in a similar fashion? If you knew where to target and how to stimulate those areas.
there might be, but the story about the brain communicating a lot is also part of the problem in Parkinson's, because I think when Parkinson's and other people describe the shaking palsy, that's what they paid attention to, the motor symptoms.
Mhm.
And you all know that it's much more than that.
Right.
And so what are the sources of that problems? And the problems with synuclein seem to, which is the protein from mitochondria stress system that seems to fail and causes idiopathic Parkinson's disease by accumulating in the substantia nigra, where this, where dopamine is produced for us normally. It has other effects in other parts of the brain, which may, my understanding is actually very limited in this, but my impression is that it interferes with the communication part of brain function. And that's why multitasking becomes a problem for people. So it may be more of a global thing, but if there are focal things in pathways that we can interact with, yes, that's the hope, that there would be treatments for non-motor symptoms. And there's been a lot of like gait problems. People have been looking at stimulating the cerebellum and cerebellar nuclei and other things for freezing of gait and stuff.
And a question I wanted to ask, a little bit transition, is there are different targets that within the brain for DBS that are considered today. So as I understand it, when early on the subthalamic nucleus location was thought of as the place to go, but now increasingly there are more patients who go to the globus pallidus, and we've talked about this before, but can you talk to us, talk to folks about why you would choose one location versus the other for targeting?
Yeah, no, and then, again, I'll talk too long about this, but a real breakthrough in Parkinson's disease was perpetrated by some illicit drug users in Northern California, where a emergency room doctor saw multiple patients in a short period of time who had Parkinson's disease at acute onset. And this was this MPT. There was an analog of, I think, Demerol or something that people were making. And actually, you'll see it in fiction. People talk about this, where they poison certain parts of the brain, and it poisoned a portion of the brain that caused Parkinson's disease in these individuals and in primates and in rats. And that became the system that when they were investigating in the primate models and the poor monkeys, that the STN, the subthalamic nucleus, which is part of the circuitry of the basal ganglia, just basically leading the thalamus, was a good target for deep brain stimulation. But the traditional target was the globus pallidus, and that's where the first pallidotomies were done, and that's where the old crusades to try to cure Parkinson's were targeted at.
Okay.
And when something's new, everyone was interested in a new target, and it seemed to work well. But I remember before so there were big studies published by the VA group, the PADREC, that UCLA was part of, and actually UC San Diego was, but we worked with UCLA. I mean, UC San Francisco and UCLA, and we worked with UCLA. What they looked at the difference between the targets, and they felt they were statistically not significantly different. But the gossip that I remember Phil Starr telling me about, he says, the Parkinson's patients who are treated with DBS in the globus pallidus feel better, but don't seem to do as well, where the STN patients do better but feel worse. And it was this kind of observation that over time, when people looked very specifically at these, could find differences, particularly in cognition. And I think the early DBSers, and myself included, really underestimated the cognitive balance of problems in patients with PD. And so that resulted in us moving from doing bilateral on everybody to then unilateral, staged, and then like Kaiser was just doing just unilateral by itself. And then understanding that cognitive issues were an issue, and you could predict those by doing the preoperative testing, was super valuable. And once we had this preoperative information, then we had patients who were cognitively intact, and these were everybody wanted those patients, but you had the patients who had Parkinson's a little longer or more cognitive issues. What do you do about those patients? Because those patients are more fragile. But now with the information that at least you knew what was happening, observationally, I think we recognized at UCSD that the GPI was a little bit easier target for them. GPI is also a little bit easier for the surgeon because the STN is 4 millimeters, so it's a tiny target, which is nice to be awake. We can listen to it, find it, but even just then there were some cognitive issues because it's basically a densely packed little target. And the GPI has a little more redundancy potentially, and it's a little bit bigger, maybe 8 millimeters across, which is miles in our business. And plus, people started understanding, there were areas of the brain which in the basal ganglia were involved in motor control, but in the brain, the motor control and sensory systems are right here, emotions are back here, and vision's back here. And it turns out the globus pallidus was organized the same thing. At the front end was emotions, in the middle was motor control or posterior. And if you got really posterior, that's where the visual stuff was going on in other nuclei, actually. So bottom line, long story short, what we started doing, and I feel strongly is valuable in the young patient, is his int is a fine target. If you're primarily tremor you're trying to treat, STN is a fine target. But if it's more cognitive issues, more dyskinesias, globus pallidus is really good for dyskinesias just by itself. In STN, it's good for dyskinesias because you can lower the medicines a little bit. But globus pallidus seems to be a little bit more easily tolerated for patients with cognitive issues and depression. So, and that was the selling point for me as far as working with big teams, where you could talk to the neuropsychologist, you could talk to the neurologist and understand these problems. And so we started, and a lot of people started looking at the alternative, the targets, and trying to really parse the no significant difference in large studies to individual patients with different cognitive burdens. And that was a big thing. So specifying kind of what did you want to get rid of? And then figure that out. Plus there's inherited disorders where it's known that STN is a more dangerous target as well. So there's a lot of stuff.
Interesting.
But bottom line is, I think both targets have utility, and if you're really good at it, fine. It's the cognitive issues. People will argue about it, but in my hands, I felt much more comfortable doing GPI on patients where there was a doubt, and a couple of patients where people said no, it'll be fine, and okay. And those patients, it maybe stuff would have not worked out so well with GPI as well, but the STN patients are the ones I remember.
So I guess my understanding is that if there is some cognitive decline in a candidate, that I thought that was just entirely disqualifying, but maybe that's not entirely.
Yes, no, very good point. Because yes, so dementia is dementia is definitely a bad idea.
Okay.
And the
Dave,
old
why?
song, well, because it doesn't help. DBS does not help dementia at all. And frequently people are devastated because of many things, but in the families where dementia is the biggest problem, they sometimes are the most desperate because they feel like they can get better with the Parkinson's medications, with the levodopa, but the dementia is still there. And so, we got talked into early in the time, doing a patient whose family was insistent that, the guy was hospitalized because of his dementia and his Parkinson's. He was in bed, couldn't move around. And he said, well, he'd be easy to take care of. And I think quietly they were hoping that they would see improvement in the cognitive issues. And you say it over again, but people,
Will not.
well, yeah, they just don't. And the thing is, I get it. You don't understand until you've been through it.
A question.
And someone says you really can't. The
I-
bottom line, that patient movement got better, but was kicked out of the nursing home because suddenly he was able to move around and couldn't stop.
I see.
And so the lesson for me was that there's full-on dementia. Mild cognitive impairment is the big box that's in. And so minor mild cognitive impairment is very common in Parkinson's.
Mhm.
And so if I don't really know IQ, but I thought a normal IQ was 100. It seems like more a normal IQ, it's like grade inflation is a little more than 100. But after 40, all of our IQs, all of our cognitive skills start to slow down. It's just a proof. It's a normal thing that people learn, started looking at patients for Alzheimer's disease, for example. But in Parkinson's, you get a different kind of dementia. And again, it's rather than a memory thing, it's a processing thing, it seems like. And DBS does not help it at all. And STN appears to be involved heavily involved in cognitive issues because of its involvement. And it turns out there's a thing called the ultra fast pathway from the frontal lobe on the right side to the STN, which helps us to make decisions. And one of the researchers explained it to me. It helps us pause so we make better decisions. And so it's easy to think about, buses, but I decide to cross the street, I see a bus, I stop. So, well, it does that, but what it really does is if I see ice cream, it's chocolate, vanilla, it allows you to chocolate, vanilla to make your decision, and I pick chocolate. But so that there's a lot of things going on. And so I think you fiddle with how you make decisions and fiddle with the processing of cognition. And then the last thing I will say is when we test people, some of the testing, if you have moderate to severe cognitive impairment, that becomes a big red flag for us. And so that's when we have discussions, and it's tough when you have a patient who's impaired and wants to be better, and then the family wants to do anything they can for them. And in the beginning, I would occasionally just, okay, we'll do it. And in the end, I would just make him come back and back and back and back, because then you take a caregiver who wants to do everything he can, and then they have a patient who is having more problems after the surgery. So, so the last thing I was going to say is that, so cognitive impairment, if you measure cognitive impairment in this certain scales, you are not demented unless your family says you're demented. If your family says, no, it's not a problem, you could have a score that, except for that denial that there's a problem, where they're already taking the keys away and that kind of stuff, then you're not demented.
I see.
And
right.
So the tests depend on some family reporting, and the most unpopular person in the movement disorder team is the neuropsychologist, because we all have some cognitive problems, and in Parkinson's, it just speeds it up. And no one likes to hear that, unfortunately.
Right.
But we're all kind of head. As a surgeon, I figured I was escaping, but no, none of us get on. Yes.
I got a little lost.
Yeah, okay. I apologize.
Globus pallidus versus
Yes.
STN.
Yes.
And so I've been taking some notes, and I have that the globus pallidus is good for dyskinesia. It's more easily targeted for patients with cognitive issues and depression. Did I write that down right?
Well, it's easy to target. It's a bigger target for us, so the bullseye is a little bit bigger. And it is our more favored target for those two disorders, but it by no means means that A, makes your depression better, or B, you won't have any problems. It's just a little bit better, and it gives us more room. And the other thing about the neuropsychological testing, if we find depression, we don't just do DBS. pause DBS. That would be my advice anyway. Pause DBS, get everything fixed as much as you can about the depression, and then make a
And
decision
then-
if you still want to go.
Right.
Well, then I have a second note. As you were talking, I was trying to keep up, and I think you said STN is heavily involved in cognitive issues.
Yes.
I was just a little confused because was it globus pallidus or STN, and I wasn't sure which was
No,
the target in which situation.
Yeah, so fair enough. So STN is better in younger patients with tremor, and in my hands, more dangerous for worsening depression and worsening cognition.
Thank you. So when you say younger, how do you define young?
Well, it's all about the doctors. So if you're less older than I am, then you're young. No, so yeah, you wouldn't want me as your dermatologist either, because you'll end up with a haircut like me. But yeah, so the 40 and 50-year-old patient tends to have a different kinds of Parkinson's disease. And tremor is a different kinds of Parkinson's disease, slower, lasts longer, doesn't have as many of the horrible things associated with. And then there's the falling Parkinson's, which we call PIGD, postural instability and gait disorder, which tends to be faster Parkinson's and is tougher cognitively as well. And I don't think people know why people get it yet, but I would bet that just different, because it's not just one magic problem that's happening in Parkinson's. It's like your car, it's not rusted in one place, there's rust in different places. And if you get it in enough places, you have trouble. Yeah,
You really hit the nail on the head with that analogy.
That's a great analogy.
When
that is a great
people ask me,
analogy.
I say, well, I'm like an old car. I need a lot of workarounds and repair.
we're all but Parkinson's adds to some of that stuff. Yeah. But and so we talk about surgery, exercise is in dementia, or at least in Alzheimer's disease, and in PD has a tremendous benefit. And I don't think it'll save anybody of any of us and anybody with Parkinson's, but I think it is a way to, if nothing else, help the physical system, and I think it does promote recovery in the brain. And there is studies that showing you need 150 minutes of exercise a month, a week. And then there's a newer study I just saw which suggested just high peak exercise, even for short periods of time, like 8 to 10 minutes, is beneficial as well. So there's something about exercise and activity, kind of the old, like Mom said, use it or lose it kind of thing. There is this connection with the brain that activity and interaction, plus human interaction, is super valuable. And if you've heard me talk, that is something that's really, they were talking about Alzheimer's disease. So dancing is supposed to be super helpful. Exercise is good, but dancing is better, because it is a physical activity, but it's also interacting with somebody where you're talking and humans are not all that way, but most, I think that's a characteristic of human beings, that we interact with each other. And that's, our brains are designed to interact with each other. And you wouldn't know it by politics these days, but I think human interaction, talking with people, whomever, is the fertilizer for our brains. And I think any of us have seen that, right? It's like when the grandkids come, suddenly grandma looks much livelier. And these are, again, I don't know, it's observation. Everyone's seen this stuff, and why and how, that's the magic. What's going on to make that happen?
So Dave, would
David-
you say that
I'm sorry.
excuse me, go ahead, Dave.
No, please, Nancy.
Would you say that a person who would not be a candidate would be somebody who is presenting with significant cognitive issues in terms of pursuing the DBS? Are there other things that you'd say, hey, that would not be that person presenting with that would not be a candidate either?
Well, so in cognitive issues, that's where getting on the train earlier is valuable, because sometimes people wait, and we know the clock is ticking on their cognitive issues.
But if they were going to develop, I'll share John's example.
Sure.
and then some of you may not know this, but John was recommended by a fellow for DBS with Dave back in 2009, and he'd been diagnosed in 2000, formally diagnosed in 2005, symptomatic since 2000. And Dave and I talked because I was suspecting at that time that John was going to get dementia. And I will admit my background is in neuropsych, so I have that training, but his neuropsych eval came out within normal limits. And Dave and I talked, and at that time, the globus pallidus was brand new as a concept and very experimental. And we decided that probably that wouldn't, I decided actually, and John, that we weren't going to have John be experimental. Then when he did get diagnosed with dementia in 2014, his neurologist who had returned, he had been out on leave, said, oh, it's a good thing we didn't do that. And just FYI, Dave, I haven't shared this with you, but John did donate his brain and spine for research, and the eval came back last July, pervasive, severe Lewy body dementia throughout his brain and Alzheimer's, but not enough for a definitive secondary diagnosis. The report was so significant, I was shocked the man was still alive, much less able to communicate with me. So when you speak about that exercise, John exercised right up until the very end. And I would have to say to you, absolutely, you are correct. I think a lot of what allowed him to continue, and that was his choice. He saw himself as having great quality of life, whether he had dementia or not. That his choice was to enjoy his life, and he exercised a lot. And that Dave mentioning the dancing, RX Ballroom Dance now is live in Central San Diego and virtual. And it's in our newsletter, or if somebody's got a question, I'll put my contact information in and send you the flyer. I'm actually participating in it because I developed double vision over the pandemic, and that the prism glasses gave me vestibulopathy, dizziness. So I asked them if they'd take a has-been care partner, and they agreed. And I'm doing it for exactly the reasons that Dave said, that integration of multiple systems in order to, create stability and smoothness of movement. Anyway, just so that's why I was throwing that out there.
And Nancy, thank you for sharing that, because I think there's a couple of points there. One is that we need, and that's the royal we, science needs more donation like that. And that's a tough decision, but clearly, I'm sure that's something John would want as well, to pass forward the opportunity to understand what's going on, because that is the source of a lot of information, the donated brains, that have allowed people to understand what's going on much better.
And the genetic studies that are going on too. There are several of them. I can't emphasize how important that is. John participated in so much research at UCSD that UCSD paid for his brain and spine to be harvested and sent back to the Mayo Clinic. I mean, that was the deal. John, you keep participating and we'll do it. And I went, okay, great. I mean, and he was very, very interested in it. But again, I was blown away at how involved his brain was by the end. And he basically died. His system stopped. So he used everything up.
Right.
Yeah.
Well, the other point about it is that we talked about the rust. So this the Lewy bodies, or the accumulation of the synuclein, and it's been told to me by Dr. Litpan, whose expertise is actually Lewy body dementia and PSP, which are the Parkinson's lookalikes, that at some point that we're going to call it Lewy body disease with motor symptoms, or movement, Lewy body disease with cognitive and memory problems.
Yeah, John definitely had postural instability gait disorder. He presented with no tremor. He was like the Wicked Witch of the West that had water poured on him. He was slowly melting.
Yeah, no, and it's tough.
Yeah. So, and again, I just, if Dr. Barba would have been his neurosurgeon, and I know him well, and I would have trusted him innately, but that was one person where I thought, oh, I'm not sure John, although I'd love to have him do that and be, well, I'm not sure John's a good candidate.
No, and I think that's where the surgeon's great to talk to, but you talk to the neurologist and the rest of the team too. I think that's the other evolution that's really been beneficial. It's like when in trouble, fly in flocks, and having all that input, and the observation. You know, I think surgeons get a lot more credit than we deserve credit, but we're experts at our one thing. It's kind of like Tom Cruise and Top Gun, that's all you hear about is the pilot. It's the ordnance guys, it's the fuel people, it's the safety people. It takes 5,000 people to get that person off the deck. And so I think all the team aspect is super valuable for the care of the patient and for the family too, because it's being a caregiver, as they say, God's work. It's a tough disease all the way around. And it's kind of like epilepsy, which is, I would always say to the students, the seizures are the disease, but epilepsy is the seizure is the problem, but the pathology, and the epilepsy is the disease. It's a whole family thing. And epilepsy is a whole family thing.
Can I just make a comment there? I think it might be useful for you to talk a little bit, if you get a few minutes, to talk about the difference in whether or not you want to do one side or two leads, one on the right side and one on the left side. I had an option to pick that, and I don't know that everybody talks about that a lot, but I think it'd be something worth talking about.
Well, yeah. Can I get your input? So did you have two sides or one side?
I had both sides done.
Okay. So like I told you, when we started seeing trouble, we went to one side. And then as we got a little bit better, we did both sides, then one side, and then the other side. But for us, the big determinant, and this is the same thing I've been talking to the guys at San Francisco, once we started doing the neuropsych testing and really evaluating people, we would just do a single side occasionally for patients with cognitive issues and asymmetric disease. And that's one of the hallmarks, it turns out, of Parkinson's. It's going to be worse on one side than the other. And if it's even Steven, well, maybe you're just a lucky or unlucky Parkinson's patient, but that also, a neurologist will probably wonder about your diagnosis if it's both sides are exactly identical. The other thing about two sides, so we test, and if patients are a candidate, they're going to get both sides, because the other problem is that when you give Parkinson's, when you do the DBS on one side gets better. And the other side may get a little better, but not a lot. And then I'm going to use the top and bottom of my glasses. And then the neurologist has to give the pills, and the pills are on both sides. And if one side, the top part of my glasses is the good side, and you're up here, well, this analogy is not working. But basically, if you get the medicines for the bad side, then the good side is over medicated. And if you give enough medications for the bad side, the good side's under medicated. And Dr. Lussig, she was really sweet about it. She goes, but Dave, we just don't want to do too many of these, because this is a real problem. And it's hard to get it right. And the surgeons get a lot of credit for putting that thing in, but the artistry, I think, is really in the neurology. And I will say that when we first started, no neurologists in UCSD would do this. And I programmed some, I tried to get some help programming, and we got a young neurologist to help me, but he was mostly an Alzheimer's guy. And until we got a really seasoned neurologist, it wasn't apparent how valuable this was, because the art is in programming. And so the neurologists now have more tools. The guided, what do they call them? Steerable current systems now give a lot more nuance about what the neurologist can do, increase the therapeutic window to make up for little things that we in the past couldn't get over with the if targeting wasn't exactly where we wanted to be. And targeting, the other side of it, just to talk about it, I became a big advocate for asleep DBS, watching what was going on in San Francisco, but also because the steerable current systems were available. Because I think what it does is it allows patients then to have more options for treatment that, it's beyond what the neurosurgeon does. It just gives more tools to the neurologist. And the neurologist is really the one living with the patient on a day-to-day basis or week-to-week basis. So I think that programming is super important. The neurologist input's super important. and the combination of the programming and the medications is a real art form.
Interesting. I was actually going to ask about sleep versus awake procedures and sort of the pros and cons of that. And do you see one of those techniques becoming essentially the standard as opposed to, you know?
Yeah, so I think that I really enjoyed awake procedures only because I felt like the patient was very safe. We could test a lot of things, but then I had a cardiac arrhythmia that sprung up, and I got treated, and they woke me up in the middle of the procedure after being under anesthesia. And it was one of these experiences where, you know, you have a gown on, you're butt naked basically, and they're asking you to roll around. And I realized it was like this crazy dream sequence from, you know, very disconcerting. I was very happy it was getting better, but completely disorienting. And I realized that this is what my patients were going through on a, you know, weekly basis. And again, I would tell them about the stuff, and I had experienced it, but I had experienced it from the outside rather than the inside. And after that, I thought anything we can do to have a patient asleep, we are going to do. With the steerable leads, we went into the MRI machine because a lot of the targeting has been worked out, and that's why the GPI is a very visible target. The anatomy has been very worked out with microelectrode recording. STN has been very much that way. Essential tremor, kind of back and forth. We've been very fortunate with and doing pretty well with but that's where there's still controversy, at least in the full asleep MRI guided. And there's a lot of tools now that allow a doctor like Dr. Benheim still really likes microelectrode recording, which I think is very valuable.
Can you tell us a little bit about what is microelectrode?
Yeah, so we
recording?
listen to the cells in the brain. That's how I sort of, you know, learned and was taught and acquired skills in, to listen for the various laminations in the globus pallidus. It's kind of like a dinner roll. So you get air and cells and airs and cells. And once you know this, you know, because it's kind of a horn of plenty, and you don't want to be too tight, you want to be too big open. Those are for GPI. For STN, it's a noisy little target in a quiet, a noisy little P in a sea of quiet. And then in essential tremor, we can listen for activity. If we're too posterior, we can hear when we touch the hair follicles. And then you can also move the arm or the leg and kind of tell where you are. But the hard part about all that stuff in the old days was the patient had to be awake. And so for the first side, they were pretty good, but it's hard to be on the table, not able to move for hours at a time. And so occasionally patients, particularly with cognitive issues, or some people just, you know, it's an anxiety producing thing.
Sure.
And so the second side was always tough if we could do the first side. And some people just breeze through it. I'm, you know, super impressed. And again, people were I feel a debt of gratitude to people who were willing to put their lives on the line, and because it's a big responsibility, obviously, for me, but it's also, the goal is to try to help. So we're all kind of working on the same team. So the listening is old school, not old school, but that's how the technology was developed. This is considered to be the way people were, the only way it was supposed to be done, and people have been taught that way. But there's a revolution now where all the major centers are doing some or all of it asleep. Just like the VA study, the big studies say there's no difference. There might be little differences. Essential tremor is still one of those areas where people want to have patients awake, and we would do some awake. But you can do, and we were doing for dystonia, but didn't do it a lot. Those patients would be asleep to a certain level where we could still listen to the cells. And now there's good literature to show that you can do that. And Dr. Benham's got this cool thing where we're doing the EEG, so you can sort of watch the computer go to sleep. And if it's completely asleep, you can't do it. And if it's like, but if you can get in between zones and discern where the cell layers are, and so I think that offers a lot of benefit. And then what's happening now is imaging is getting better. There's a thing called tractography, where you can, the computer and the MRI neurologist are able to discern which way the wires are going in the brain. And since we know the anatomy enough, we're getting better at knowing where, it's kind of like pulling out the weed, and at the bottom of it's the cells where it's all coming from, and figuring out how to follow the track back to where that the root ball is. And that hasn't been completely tested out, so we're still in the learning curve of that. And I also think the stereotaxis is getting much better. So the technology of getting to the right target is improved a lot. Our ability to see the target, our ability to see the networks inside the target, and then our ability to improve how we program are all moving it so that asleep, I think, is a much more reasonable way. And in experienced hands, if someone asks me, if you want to be awake, we can do it, but in good hands, go get a sleep surgery.
Dave, I have a question.
Sure.
If you were going to go in,
Yeah.
what's the procedure with you guys? I mean, I realize you're retiring, but what's the normal procedure? I've
Well,
been referred, and
yeah.
how long would I expect the surgery to last, assuming it's bilateral?
Okay.
The other thing is, I happen to have an opportunity to see somebody where I know the electrodes went in to the globus pallidus, and I was stunned. I expected the little bumps here, but what I saw was a flap here. Now, am
Yeah.
I? So
No. So the hardware, when we were doing in the very end, we were doing a sleep DBS, and the frames, in order to get them to really stick, we were making bigger incisions so we could lock them to the skull. There are scalp mounted systems which are smaller. The concern I had over time was that if you're making small incisions and you can't get the incision away from the plastic, that was something I was trying to do. And I only had it a couple times where the skin would open up, because the skin likes to heal right over the bone. And if there's plastic, sometimes it impedes the healing.
and the plastic is the top of the electrode, right?
Well, it's there's a cap that goes on. So the
Right.
electrode is small, like a spaghetti noodle, but then there's a cap that's about like the size of a quarter with a nickel on top
Yep.
of it, which is the little bump.
Yep.
And that's not very big, but it's about 14 millimeters. And if the
Okay.
incision goes over there, I had one open up on a mother of an orthopedic surgeon. It's always the doctor's families. So I modified how I was doing the surgeries. And so even when I was doing the minimally invasive asleep, the skin incision was tremendous.
Different.
There are better technologies. And that's one of the things actually I'm hoping to consult on, actually, is how to secure these things to make it viable outside of the academic institution. And again, people have a lot of experience and have ways around it. But I think that the older soldiers still tend to use a slightly bigger incision just because they've lived long enough to see some of the other things happen. But increasingly, there's going to be incisions where you can just make a stab incision, make a hole exactly in the path you want to go to, and then put the electrode in position. So each system has a different way to do it. The asleep DBS and the MRI machine involves either a curvilinear incision. We were making pretty large incisions in the scalp and then closing them up. But we'd make a burr hole, leave the covering closed, because the mapping technology allowed us to see where the veins are, and we'd plan for all of that. And then you could guide, before you put anything in the brain with the covering the brain closed, guide your trajectories on both sides using the MRI scan sequentially to take a picture and slowly aim the device. It takes about half an hour to 45 minutes to get the thing lined up on one side and then the other. And then the San Francisco people would put the electrode in halfway. We would, and basically technology's changed. We had to use a ceramic pasta, a spaghetti noodle, basically, that was inside the thing because you couldn't put metal inside the machine. All the technology is changing. Medtronic is now safe in the 3T magnet. And so we still did the technology where basically we put the targeting electrodes, the guide tubes into position, confirmed that we were in the right place, moved in if we had to. That was very rare. And then basically used the guide tube, took the little spacer out, the ceramic, we called it, and then slid the electrode in. If we had to with Medtronic system, we'd confirm with one more MRI, but just measure things out and then lock it in place. For the MER, basically, it's a similar thing, except it's a metallic device that can be slid over the head, or there's robots that are doing it now. There's still discussion of if they're accurate enough. But so there's a lot of evolution in how to target. But basically, those systems, either you just put it in or use microelectrode recording in the patient that's partially, that's basically sedated so they're not aware, and you can use the microelectrodes to confirm. And then that's kind of mama for me. Then that helps you know depth and a lot of things which give security about the rest of it. But increasingly the systems are very accurate, and if you're experienced with them and use them, you have a system you like and your team knows what's going on, that those can be super accurate. And the need for microelectrode recording, I think, is slowly disappearing. There'll be some use for it, but I think there's new technologies coming out.
So
What
I'm
was your question?
referred for DBS.
Okay. Yeah,
I
right.
would make an appointment,
Yeah.
but the first thing that would happen is the MRI before I actually meet with you.
Well, so in movement disorder at UCSD, so there's kind of there's two, and I also said I was raised by neurology wolves, so I enjoyed hanging out with a neurologist, and so the neurologists are very deliberate about things, and that process we got down to 2 weeks, but it's up now. So what usually happens is you start with a neurologist. They'll determine, and and they will also, it's impossible for them not to want to try to adjust your medication, so they'll usually do that. And then if they really feel like, and you make strong enough case, and that they feel like you're a justified patient. And I think what's also happening, where before we had to get it all perfect, we want it perfect, but if they knew you have Parkinson's, you have for 4 years, there's less and less, well, we'll just wait until you're really sick and then do it. I think people are getting on the DBS bandwagon earlier to allow patients to have the benefit of it. But so then when the trigger's pulled, we're going to have it. Then you usually come and meet. You would in the past meet Kathy and I, and she'd do an on and off evaluation. So you have to come in off medication, and then be videoed, and then see me, and then be on medication for an hour or so. Sometimes medication, like 1.5, so we could make sure we really saw what was going on. Look for dyskinesias, and video again, and then you'd also see physical therapy, occupational therapy, and neuropsychology. Neuropsychology is, as you know, being in business, it can be a full day testing. But what that allowed us to do is predict a lot of problems beforehand, and then there'd be a presentation. When we first started doing, we do MRI on everybody. In the later iterations, they would wait to get the MRI scan. If we had like an old scan, that would be fine, but we'd want to get an MRI scan within a year, just so there were no surprises. If you were awake, we'd do some other stuff, and MRI scan the day of surgery using the MRI machine. Now, the other model, which actually Phil Starr started to use, it's telling me I'm having trouble, so I'll go off it, is that he would sort of evaluate patients and work with the clinical neurologist on the outside. This is more Sharona Benheim's model, where they don't do as much detailed testing. But as long as we're working, because there's a lot of movement disorder neurologists now, more than there were before in the community, and in Temecula, in El Centro, not El Centro, Palm Springs and such. So we'll work with, so if they have come up with the evaluation, or in the SHARP system, and they've done the evaluation and they're convinced that it's a reasonable thing, we would ask to get the imaging study, all the tests we could get, but if we could only ask for one, I would want the neuropsych testing, and then work with the neurologist. So that process could take to a couple of weeks to months. We had one lady where we discovered she was a hoarder. We wanted to see psychiatry. It took 2 years. But we ended up, she was still interested, and she didn't have anybody at home. She had a friend who was a nurse and helped her. she went ahead and had her surgery and did just fine. But where I was always a measure twice cut once kind of person.
Yeah.
And I think Dr. Benheim's system of working with a neurologist is a good one too, but that again is a partnership with both sides of the team represented and talking about what the risks and benefits are.
Well, it's helpful because John was referred in 2009.
Yeah.
And at that time, I was just told by the office, you have to come in for an MRI and you have to promise that you'll have the DBS within 6 months. And I said, well, wait a minute. I said, my husband's going to be in a huge trial and we're
Yeah.
not going to, and that's like at month 5, we're not going to do this before.
Mhm.
And then I began to have some suspicions in terms of cognitive function, which then made me stop and go, oh, let's get a cognitive eval.
Yeah.
So no, that's helpful. And then how long, if I'm the patient and I arrive and I'm in pre-op, from pre-op until I'm heading out the door, how long is that?
When the awake procedure is, well, you'd be out the door the next day. And that's the liberating thing about the neuropsych testing as well, that if you have neuropsychological testing and normal, 99% people go home. They a sleep surgery and the MRI scan, sleep at 7, wake up at between 2 and 3. So, if mostly it's the skin incision that takes a long time. When we were doing awake surgeries, we would do 2 surgeries a day and be done by 3 to 5. But then I would always, I felt very strongly I wanted to see that patient myself. And 80%, 90% of patients go home the day after surgery. And if there's any other issues, we had, well, in the last 2 years, one patient that stayed for like a couple of days. That was one of these STN patients where, in retrospect, I wish I did it differently. But we also had like this old professor at UCSD, because again, the IQ points are kind of like a water in the tank. You can put extra in there if you have extra education. And he lived with his wife in one of the Casa de Mañana kind of places in La Jolla. And so he had some more trouble walking around, cognitively not perfect, but doing okay. And I thought, okay, well, this guy's going to have to go to the nursing home. And they said, okay, fine, we'll arrange that, because where he stayed, that was an option. Saw him Saturday, didn't see him Sunday, came in Monday for day 4. I go, okay, we're all ready to send you there. And he goes, no, I'm fine. I'm going home. So if you were safe on the cognitive score, it wasn't a guarantee, but then that was usually very reassuring that patients would go home soon, even if there was some, a couple of strikes against you.
And then the
patients
programming
under the age of
happens,
60, 24 hours. What's that?
programming happens, what, a couple of weeks out?
Yeah. So there's a thing called a micro lesion effect, because in the old days, in pallidotomy, you'd make a hole in the brain using electricity or current, heat, alcohol, whatever they used, and you'd get some sort of bruising. It's kind of like if you sprain your ankle, it swells up and then that goes away. So if you had a little of the swelling from the lesioning that made the lesion seem a little bit bigger right off the bat, it would get smaller over time. So some patients from pallidotomy had to come back and be done a second time. That's one of the risks of focused ultrasound, I think. But in DBS, sometimes you see minor improvements where the tremors will go away or they need a little less medication. And I'd say maybe 30% of the time that would happen, micro lesion effect. So the neurologist wants to see the patient when they're back to their native state. So usually they would want to wait a month, because it made programming very hard, because if they were pretty normal, you'd program them for that. And then over time, the Parkinson's would come back and the programming didn't look like it worked. And it would be upsetting for everybody. So they wanted to get the testing done and turn them on with a delay of, at least for us, for like at least 3 weeks.
Got it. Okay, thank you.
And we were also putting the batteries in 2 weeks later, so the patients didn't have to be asleep too long. Although if it was necessary, sometimes we did that, and we just, we had to accept that extra time.
And then can you typically expect the electrodes to last the rest of your life, but you have to have a battery change out every so often?
Super good question. Yes, the electrodes in, those are the things we don't want to have to change. They're made very robust. The connecting wires have been improved to the point where they're stretchy and very firm. So it's the battery that has to be changed. And in the old days, the battery would be changed every 4 years or so. And in some patients with high current need sooner than that. But increasingly patients are, again, this is sort of the next phase where patients realize, okay, this is going to work. I'm going to use a rechargeable battery, and it's like your cell phone. And then the batteries are theoretically supposed to last like 6 to 8 years. You said Bobby, you had a rechargeable system in?
You're
You're
muted.
muted.
Yes, mine is rechargeable. It's supposed to last, they tell me 9 years, but it is rechargeable. I have to charge it about every 2 weeks or so for a little while.
Yeah. Well, and that's where cognition's an issue. You have to be with it to be able to do that. And it's not rocket science, but you have to remember, you have to be
Right.
willing. And in the early days, it was still slightly, I don't want to say magical is the wrong word, but people didn't want to think about their Parkinson's anymore. So they didn't want to, they just want to take their pills and just go. So I think we are moving into a new phase of what, how DBS is being thought of.
Dave, looking forward, I know you're in a transitional period for yourself and how you look at this, but if you could imagine some next level technology, what would that look like?
For DBS?
What would you like to see? Yeah, or
I would
actually
like to-
based upon your experience with Parkinson's, what would you hope for as the next big thing?
Well, I'm still hoping that the new therapies for Parkinson's disease will come about and allow patients to have improvement of their symptoms, or maybe even stabilization of their disease with a gene therapy thing. The things that I'm aware of that I can't really completely talk about still involve a brain operation. The lesion things might work, but that's kind of, we've done a lot of different things with lesions, and so I'm not sure that's the way to go, though. We're interested in pursuing that, and it's happening around us, so that's a thing. As far as technology, again, you're kind of spoiled by what you've already seen. So the idea of having the pacemaker technology advance to where it could be more real time and linked so that it would be tailored to your individual situation, that's not here yet, and I think that will be around. Frankly, what's going on is that when I talked about Dr. Starr's videos and stuff, they had a picture of the patient driving around. You could see their beta frequency changing. There's a lot of information, and so I think it's getting it into a palatable form, so that the patients can be programmed around that will be, I think that'll be a valuable tool because it'll be tailored to individuals' disease and their activities as well.
Right.
And I think imaging too. I think imaging is going to continue to improve, targeting, and nuances of that may be.
Right. Are there? I'm sorry, Robert.
It's okay. I'm just curious if you see anything on the forefront helping for the anything non-motor. Is it all just going to be stay motor?
I know a lot of people are working on stuff, and there are people talking about stimulation, but I've been at it long enough where I'm seeing people talk about the same thing a second time, where it's hopeful, but that sometimes it's just not the right idea. And when we were talking, like Nancy was talking about Lewy body dementia, where the frontal lobes and the cognition's impacted, the people are looking at these inflammatory, I think that my take on it, again, this is completely talking out of my fanny. I believe that's more of a systems problem and more of a generalized problem. So if there's some way to prevent the synuclein, and that's really dream stuff, would be to somehow stop the disease from this multiplication of the problem, because it's basically a snowballing effect.
If there's a biomarker you could detect early on before there were symptoms, for instance, and had some way of monitoring that.
Yeah, modify the disease,
Right.
and people are talking about more sleep and all this other stuff. we're not there yet, but that, if we can't cure the disease, if we could somehow figure out how to inhibit
Push it,
it, push it down the road, or at
slow,
least-
slow the progression to the point that something else kills you.
well, sadly. And again, sometimes, because we were going to be involved in Huntington's disease, and that's the tough thing. So Huntington's, we know the gene, we know pretty much the anatomy, and there's still interest in gene therapy, but we're still stuck behind that one. And the AADC thing was nice because it was a single genetic problem in a young individual where there was all the upside available. Yeah, so there's
Less
plenty of
complexity.
opportunities for improvement here.
Right, right.
I have a question about stem cells. There's
Yeah.
a lot of information coming out about working on stem cells that can produce dopamine. But my understanding is that it's not only those neurons that are damaged. For example, when you lose a sense of smell or taste, that's a different part of the brain. So what I'm thinking is that Parkinson's seems to have damage going on in various parts of the brain. So replacing the dopaminergic neurons is only going to be just one piece of the puzzle. Is that the case?
You have articulated a very important point, which is done it very nicely. So we talked about stem cells and then implanted cells, and so the Swedes were doing that. And then, like Nancy talked about, there was donation of the brains, and what they found is that in these normal cells, and this is part of what nailed down what was happening in Parkinson's disease, that in the normal cells that have been implanted, they, in the patients who succumbed to Parkinson's, they had synucleinopathies inside their cells. So it's like the rust got into the new cells somehow. And I think your example for the problem is exactly right, is that it's a system-wide problem that we see in motor control, and we deal with that because we can fix that. But how to slow down the rest of the changes that are going on, that's the real problem. Because just like you talked about, and have you guys heard of, what's this guy's name? The Brack hypothesis? So he's a pathologist from Germany who everyone thought was crazy. And what he saw was that he could see synucleinopathy in various stages in patients that appeared to ascend in a nerve that works in the intestines called the vagus nerve that goes to the brain.
Right.
And then when it actually got to the motor control areas, the substantia nigra, that's when you had Parkinson's disease. But that this was a progressive disease that went from neuron to neuron to neuron, and spread sort of like there's this thing called mad cow disease called prion disease, which are protein diseases, which another person was called crazy for as well. The guy won the Nobel Prize, where he noticed that this disorder was this creepy change that happened and I say creepy because it would go from organ, part of the brain to part of the brain to part of the brain, that would go through the brain. So people thought there was viruses and everything, but he proved there was this protein abnormality, and that thing of a protein causing more trouble appears to be what happens in Parkinson's, where the synuclein is a protein that gets modified, and once it's abnormal, it teaches all its friends to be abnormal, and they stick together and create these Lewy bodies, which is identified as Lewy body dementia, which is identified in Parkinson's disease. So these sticky cells and how they start sticking is a basic problem that we still don't understand, and people didn't even believe existed 10 years ago. So, and it seems to be involved in Alzheimer's disease as well.
So if we were to totally cure Parkinson's, we'd have to replace neurons all over the brain.
Yes, so that's kind of the I'm not into gardening yet, but I want to be. But it's, yeah, if you see the pest, we need to stop the pest when it's on the rose plant, the rose bush, and then before it gets the rest of the plants, because that's a tall order, like you say, because that would be the answer. But how do you do that, or how do you get it out of there?
Right, and not only do you have to replace parts all over the brain, you have to get the rust out, as you pointed.
Yes. Well, and then and people are trying the immune system, and maybe that'll work, but the immune system Yeah, I was very interested in immune therapy for brain tumors, and I go, "Is there a book for this?" They go, "Nope, not yet," because and people are getting better at it. But the immune system is just as complicated as the brain. Although I think people are starting to see possibilities. But and you want enough, but not too much, because the immune system turned loose on the brain is like multiple sclerosis, basically. So
Wait, you said, say that again,
the
about
immune
multiple
system that's
sclerosis?
attacking the brain is, well, there's many versions of it. There's immune encephalitis, there's immune system acting against the insulating cells, which is basically multiple sclerosis.
Mhm.
And how the immune system is organized is kind of like a brain that's not a brain. In fact, maybe it's an old-fashioned brain where chemicals are telling cells to make different changes, and then they're creating these explosions of cells that are going to fight off a certain disease. Yeah. So I can.
It's
I
incredibly
was pretty
complex.
naive when I started, and it's amazing to see the body's a beautiful system. But I think you pointed out that's the real problem with Parkinson's is all the cells are getting this. How do you do it? And so far, that's where David brought up trying to find biomarkers so we could see early enough, because if we could interact, if we had a good therapy, which we still don't completely have, the time to act would be when you have the first sneeze of Parkinson's.
Well, in 1997, I think it was, I noticed I couldn't smell the scent of a particular rose bush that I really, really liked.
Yeah,
That was 97. I was diagnosed in 2017.
right. And it has the smelling problem, and that's where you need a really good neurologist to really be, listen. Well, I can't smell. Well, you're probably just, your nose is clogged up. I'll see you tomorrow.
Yeah, I mean, I didn't think anything of it. I just thought, oh, I'm probably getting older.
Right. And that does happen, but it's a kooky thing. But anosmia, the inability to smell, is heavily associated with this stuff. And the kooky thing, which I love about it, is that that was the cells in the nose were the first cells to be noticed to be dividing cells in the brain, because the neurons in the nose have to be replaced like a light bulb that burns out after a couple of weeks. And that's where people realized, no, this idea that the brain is static is just not true. And some of that work was done here at the Salk Institute by a guy named Rusty Gage, who I had the opportunity to work with a little bit. And, and that's where research, looking at brains of people who've had this disorder to understand what's going on, looking at, what are the possibilities to do this? And and that's why I'm getting out of business. There's a lot smarter people standing in line behind us who are ready to take this on. And it's like building the Empire State Building one brick at a time. But if you keep putting a brick in, you'll get there.
Well, thank you for spending so much time.
My pleasure.
I
Thanks
appreciate
for-
your patience in answering my questions.
No.
Yes,
This is-
good questions, Lee.
Yeah, exactly.
Very good.
You're asking all the questions that all the scientists are asking.
Well, I really appreciate that we've had a discussion, because usually I just sit there and listen and I can't really ask. I write something in the chat and it may or may not get answered. And so this has been so valuable and I really appreciate it. And I appreciate David and Nancy for setting it up for us.
No,
Dave did.
this is a good thing. Well, and pass it on. That's the thing. So I don't know how we get more of this, but yeah.
Well, I'm going to try and find a book
Okay.
because I
That'll
think
be
I
our
need a
next
little
step.
bation
Let
education.
me tell you my story. So when I went to medical school, I wanted to be perfect. And I would go every week to the bookstore and look for the book with all the answers. Still
Still looking.
yeah. So, but yeah, just learn a little bit each time and learn.
Learn and listen and think. It's
Yeah.
interesting.
No, because
I know
you're asking the
I know-
right questions. You're on the right track.
I know
That's
what you
what
mean
happened.
about books. I went back to Davis after UC Davis after
Yeah.
20 years working for a second master's. And the bookstore was like the candy shop to me. I came home with so many books.
No, you
was
want to learn
crazy.
all this stuff, right?
Not necessarily on what I was studying, but it was just something I was interested in. So I bought the book.
Good. I'm with you.
Well, Dave, thank you so much for this. This is
My
just such a
pleasure.
gift. And again, congratulations on the retirement. It's the best job you'll ever have because you get to do what you want to do.
Yeah.
Um, And we look forward to seeing you around in the community, Phil.
Good. I
Not
hope to
letting
be
you
able
go.
to help more in the future. Good luck to you
Thank
guys.
you.
Great
Thanks
talking
so
to you.
Thank you so
much.
much.
Dave. Appreciate it a lot. Take
Thank
good
you.
care.
Take
Bye-bye.
care, everybody.
Thank all of you.
Bye-bye.
Thank you guys for joining us. Robert, thank you
Oh, you're
particularly
welcome.
for taking the
Thanks,
time.
Lee.
to-
It's great to see you, Lee.
Thanks
You
for the
too,
info.
David. Long time.
Thanks, appreciate it.
Awesome.
Take care.
Bye-bye.
Bye-bye.
Bye.
Bye-bye.
Thank you,
Lee.
Robert.
Thank you. Thanks, Bernie.
Great joining
Thanks,
us.
Mary. Bye, Robert. Thank you very
Thanks for
much.
joining us, Robert.
And you
That's
got
very-
the text from me about Ed still looking for the chest pack.
Okay,
All right,
Very-
so hopefully he'll find that and get it to you.
all right, very much. Thanks.
All right,
Thanks.
see you later. Bye-bye. Take care. Dave, something that occurred to me that we might want to think about with this because of the format,
Mhm.
maybe just making it an audio recording.
Absolutely, we could do that.
That, like a podcast, for lack of a better description. I don't know if that's something that
Oh, I think I can do it.
oh, okay,
I
perfect.
think because I've got the recording, I can actually just separate out in fact, to be honest, I believe, I may be wrong, but I'm pretty sure Zoom created an audio recording that's separate from, there's a video with audio
Yes,
in it.
there
and I
is.
think there's also an audio recording.
Yes, because I kept thinking, oh, should we make him speaker? But then he was fading in and out, and then I thought, well, maybe we just make it a podcast. And then
Yeah.
people who didn't attend could
Yeah,
you know,
you're right.
listen to
In,
it.
in fact, the voices are distinct enough that there were no diagrams. I mean, I think that's a really great idea, actually. So maybe I'll put together both. So tell me when I've been doing this I actually am involved in a couple other speaker series. And lately we've transitioned to live streaming to YouTube, which does two things. It allows people to actually watch if they choose on YouTube, but also it sets up the video on YouTube for posterity. So there is no transferring of giant files or the processing is much easier. You could do it right through the YouTube application.
So my only concern with that is that, do we have signatures? I mean, in Central County, what I would be saying is we need signatures from the participants that they're okay to be viewed online. And I know for a fact, somebody like Lee would say absolutely not.
Yeah, and in fact, you're right. And most of the time when the way the streaming works, when you have the speaker do a presentation, then all that's recorded is the speaker and the presentation. So that
Right.
eliminates that whole issue. But you're right, that's a problem.
Yeah, if
So
we have a speaker and you can set it up so that you hide all the
participants, and
participants. I
that
think
eliminates that.
That's great, but
Yeah.
my worry is, and in this, I kept looking, going, okay, how are we going to do this?
Well, and we could have, I actually thought about, there's the spotlight feature with Zoom,
Right.
right? We could
Right.
have set that
Well,
up.
I almost transitioned to that, but I thought
Yeah, I was doing the same thing.
what I find sometimes, especially with somebody like Dave, I got the sense he had a bunch of slides, but nothing that was an organized presentation.
Yeah.
And I thought maybe this is an opportunity to sit and pick somebody's brains. And of course, Lee is the perfect picker.
Do you know Lee very well?
Very well, yes.
Yeah. We've known her for years in support
Yes.
group,
Yes.
and she is brilliant. She
Mhm.
can be sometimes a little bit troublesome, but the overall package is always 100%. I mean,
Yeah.
it's just, she's great. So that was
Absolutely.
terrific.
Absolutely. No, I just thought, okay, I'm sitting back because she's gonna take Dave on a ride here. And I'm sure for her, I mean, at one point when Dave said this is a family affair, and I thought, not for everybody, it isn't. And
That's
I'm
true.
thinking about Lee.
Lee,
and I almost said
that's right.
something. I thought, well, Lee will probably
Flying
say
solo.
bugging her.
That's right.
Mhm.
Yeah.
And I
right.
thought, well, Nancy, just keep your mouth shut. Don't.
No, that worked out really nicely, and it makes me think that maybe for the next one, I might actually go back to the neurologists who are involved in DBS, because Dave's perspectives were great, but I really appreciated, and it reflects the experience we've had with DBS here with
Right.
David.
Right.
That to have Kathy, maybe do something similar with Kathy or a neurologist. I'm not we have to think about who that could be.
But see, Dave filling me in like, I'm like, oh my gosh, so much has changed, because it's not like I'm taking somebody in, but people ask me.
Oh,
Or the whole thing about the incision, the minute he said that, I went, of course that makes sense. If you've got something right here and you've got the incision and it's getting
on
irritated,
top.
doesn't that make total sense?
Yeah. And in fact, that reflects what David has. David
That's
had
what, that's
this-
what I
this
was
giant
talking about.
flap.
It was, that
Yeah.
was the picture you showed me. And I'm
Right.
like, wait a minute, what? And then when I asked David, and you said, oh, we went into the globus pallidus, and I'm like, what? And so I'm trying to think, well, how did that make the difference? But he was probably doing a loop like this, doing
Stay
a
away.
flap.
Exactly.
Yep.
Right.
Doesn't matter what happens here, because this isn't going to get irritated.
Right.
Made
Right.
so
And it
much
actually
sense.
healed up really, really pretty well. The other interesting thing I heard was that they initially took DBS into the globus pallidus because they've been doing these pallidectomies.
Right. Well, when he
So
said
as the
that, I
target, and
immediately,
then
Yeah.
someone said, "Hey, STN might actually be good." So then they all,
right,
everybody switches over to STN. Then they say, "Well, wait a minute, maybe we try coming back here to globus pallidus." And it's all based on observation. So much of this is almost based upon you sort of feeling your way around and what's your feeling about this. We try to standardize everything so much, and it's just impossible.
well, and when he was talking to, I went, oh, but of course, because I've always sort of thought, I know someone who's in the wings from that original group to get the stem cell transplants.
Oh, yeah.
And then was off the group and now is back in the group, but can't talk about it and hasn't done anything else because you need to stay kind of clean.
Yeah.
For that.
Well,
And I keep saying, oh, you want to think about X or Y.
yeah.
But, and when he talked today and he said, hey, just because you transplant them, number one, how many do you do? And number two, they're immediately victim to what's going on. And I thought, how silly of me. Somehow I hadn't.
There are a lot of reasons why that whole project is troublesome,
So.
And what actually annoys me, and this I would say out loud to almost anybody, is frankly, I think they've led people on. I know they've led people on. When we started this whole thing, when I first heard about it in 2013, something like that.
I remember it.
They were saying it's going to, people are lined up for next year.
Right.
Just nonsense. That was nonsense.
Well, the other thing that to me is really interesting, when then there was the split.
Yeah.
They function as a completely autonomous entity, really with no interaction with our community. I'm at the Young Onset Support Group on Sunday, and a fellow who, nice guy, and he lives with his mom, and he's got Parkinson's, and he's trying to make things work, and he asks a lot of questions. He goes, he had an announcement